Look at your hands right now, not quickly. Actually look at them. You can feel completely fine, you can sleep well, eat reasonably, exercise occasionally, and walk through a year of routine checkups without a single alarm raised. And while all of that is happening, your hands are running a parallel diagnostic on your entire body, your liver, your cardiovascular system, your nervous system, your metabolic health, your neurological trajectory, and they are displaying the results in plain sight. The problem is that nobody told you what you are looking at. There is a named protocol at the end of this video. It is called the grip audit. Three components, specific numbers for each one, and one mistake that invalidates the entire thing if you do not correct it first. I developed it after spending several months going through every major longevity and aging study I could access on hand, physiology, grip strength epidemiology, and peripheral vascular biology. I will walk you through all of it. But first, you need to understand what is actually happening in your body right now. Because some of what your hands are showing you is precisely what the standard annual wellness visit is structurally designed to miss. I am Carol. I read the clinical literature, the meta-analyses, the dry institutional reports, and the boring stuff, so you do not have to. And 5 years ago, my husband, a chronically overworked entrepreneur who had not genuinely listened to his body in a decade, had a cardiac arrest that nearly ended everything. His doctors, who were excellent at the acute intervention, put him on a stack of medications afterward and told him to manage his stress, as if the word manage were a mechanism, as if the biology of a 53-year-old cardiovascular system were going to respond to the instruction to relax. What actually rebuilt his health, and I want to be clear that results vary, and everything we did was with medical supervision, was understanding how the body ages after 50 on a mechanistic level, not inspirational advice, not detox plans. The actual biology, the actual leverage points, the things the standard annual checkup is structurally designed to miss because it was designed around prescription management, not long-term function optimization. That distinction, once you see it, changes everything about how you approach the decade you are in. So here is what is happening in the background of your body right now, and why your hands are the most underused diagnostic tool you own. The invisible villain in this story is something called sarcopenia. That word sounds technical, but the concept is devastatingly simple. Starting somewhere between your mid-30s and mid-40s, your body begins losing skeletal muscle mass at a rate of roughly 3 to 5% per decade. After 60, that rate accelerates to approximately 1 to 2% per year. And what the vast majority of people never realize, because this is genuinely, almost inexplicably, never explained in mainstream health communication, is that this process is not just happening in your thighs or your lower back or wherever you first notice it. It is happening in your hands. The intrinsic muscles of the hand, the small muscles nestled between your metacarpal bones and across the palm, are among the first anatomical sites where the signature of systemic muscle loss becomes visible, measurable, and biologically consequential. Your grip strength is not a vanity metric or an athletic curiosity. It is a proxy for everything happening deeper in your biology. We will return to this in detail. Sign number 6. Your nails have changed color, and you assumed it was aging. Look at the surface of your fingernails in natural daylight. The color you see in the nail bed, the area beneath the translucent nail plate, comes from blood moving through a dense network of capillaries just beneath the surface. That means when you look at your nail bed, you are looking at a real-time display of your peripheral circulation and, by extension, your organ function and metabolic status. That is not metaphor. That is physiology. There are two specific nail color patterns I want you to examine. The first is called Terry's nails. This is when the nail bed appears almost entirely white or pale, with a narrow, darker band of reddish-brown at the very tip, typically 1 to 2 millimeters wide. Terry's nails were formally described in the medical literature in 1954, and the decades of research that followed established their association with liver cirrhosis, congestive heart failure, and type 2 diabetes at rates that are not subtle or borderline. A study published in the Archives of Internal Medicine documented Terry's nails appearing in approximately 80% of patients with hepatic cirrhosis, The mechanism is specific and worth understanding. The whiteness occurs because reduced blood flow to the nail bed causes the underlying capillaries to compress and the connective tissue to undergo partial fibrosis, meaning it thickens and loses its normal translucency. Think of it like a garden hose with the pressure cut by half. The hose is still there, the water is technically still running, but what it delivers to the endpoint changes. And that change shows at the surface, specifically at your fingernail, before it necessarily shows anywhere else your doctor is looking. The second pattern is called koilonychia, or spoon nails, where the nail develops a concave, scooped shape, almost like tiny, shallow cups that could hold a drop of water. This is a textbook sign of iron deficiency anemia. But here is the specific reason it matters after 55. In older adults, iron deficiency anemia is frequently not a dietary problem. It is frequently a symptom of something upstream that nobody investigated. Slow gastrointestinal bleeding from polyps, which become increasingly common after 50, can produce iron deficiency without any dramatic symptoms. Impaired iron absorption caused by low stomach acid, a condition that becomes more prevalent with age and is dramatically worsened by long-term use of proton pump inhibitors, the acid-suppressing medications that are among the most prescribed drugs in adults over 60, can produce the same deficiency. So spooned nails are not asking you whether you eat enough spinach. They are asking whether you have had a colonoscopy recently and whether anyone has reviewed the long-term metabolic consequences of your reflux medication. Sign number 5. You have horizontal ridges crossing your nails. They appeared at some point in the last few years, and you assumed they were just a texture quirk. These ridges are called Beau's lines, named after the French physician Joseph-Honoré Simon Beau, who documented them in 1846. Doctors have known about this marker for approaching 2 centuries, and it is still not something most adults over 55 are ever taught to look for on their own hands. The mechanism is elegant in a clinical, slightly unsettling way. Your nails grow from the nail matrix, the tissue hidden just beneath the skin at the base of the nail, under the cuticle. That matrix is a continuous production line, generating nail cells that harden and push the existing nail forward at approximately 3 millimeters per month for fingernails. When your body experiences a systemic disruption, a serious infection with high fever, major surgery, uncontrolled diabetes, a prolonged period of severe malnutrition, significant kidney disease, or even an extreme and sustained psychological stress response that activates the body's emergency signaling cascades, that production line slows or temporarily shuts down. A horizontal groove gets stamped into the nail plate at that precise moment. As the nail continues growing, that groove travels forward toward the tip, like a timestamp embedded in the nail. You can actually estimate when the systemic disruption occurred. A Beau's line sitting in the middle of a nail growing at 3 millimeters per month means the disruption happened approximately 5 months ago. Research published in the International Journal of Dermatology has documented Beau's lines appearing in patients following myocardial infarction, heart attacks, as a delayed marker of the acute systemic shock the cardiovascular event imposed on the body. Patients who had no idea they had experienced a cardiac event, or who had experienced what they assumed was indigestion or extreme fatigue, have been identified in part through the presence of Beau's lines discovered weeks later during unrelated skin examinations. If you look at your nails and see these transverse grooves and cannot identify a clear, obvious external cause, no surgery, no documented illness, no extreme dietary restriction, that is a conversation worth initiating with your physician. Not because a ridge in a nail is a diagnosis, but because it represents a documented biological record of a systemic stress event that may warrant retrospective investigation. Sign number 4. One or more of your fingers is bending toward your palm and will not straighten fully without resistance. This is Dupuytren's contracture. It typically begins as a small, firm, subcutaneous nodule in the palm, most commonly near the base of the ring finger or the little finger. Over months to years, that nodule evolves into a thickened cord of fibrous tissue that traverses the palm beneath the skin and progressively contracts, pulling the affected finger or fingers into a permanent, partial flexion. By the time the curling is visible enough to notice, the disease has usually been developing for a year or longer. Here is what the mainstream conversation around Dupuytren's almost always misses. It is not a hand disease that happens to some people. It is a systemic metabolic disease whose most visible expression happens to be in the hand. The pathological process involves the abnormal transformation of fibroblasts, the cells responsible for building and maintaining connective tissue, into a contractile, scar-producing cell type called myofibroblasts. This transformation is mediated in significant part by a signaling molecule called transforming growth factor beta, TGF-beta. That same molecule, in the same elevated concentrations, drives fibrosis in the liver, inflammatory scarring in the lungs, and vascular wall thickening that contributes to atherosclerosis. The hand is not a separate story from these processes. It is the same story told in a location where you can see it without an imaging machine. The epidemiological associations are well documented. A large registry-based cohort study from the United Kingdom found that individuals with Dupuytren's contracture carried a statistically significant elevated risk of type 2 diabetes, liver disease including alcoholic cirrhosis, and seizure disorders treated with certain older anticonvulsant medications. Dupuytren's contracture affects approximately 8% of men over 55 of Northern European ancestry, and its prevalence increases consistently with age. If you are feeling something firm and cord-like in your palm that you do not remember being there 5 years ago, bring that to your next medical appointment, not as a hand complaint, but as a trigger for a broader metabolic assessment: liver enzymes, fasting glucose, HbA1c, full lipid panel, and potentially an ultrasound, if the clinical picture warrants it. Sign number 3. Your hands are frequently cold even in warm environments, and your fingertips take longer than they should to recover their color after pressure. There is a test you can perform right now. Press one fingertip firmly against a hard surface for 5 full seconds until the skin blanches white. Then release it and count the seconds until the normal pink color returns. Under conditions of healthy peripheral circulation, reperfusion happens in under 2 seconds. If you count 3, 4, or 5 seconds before the color normalizes, that is called prolonged capillary refill time. It means blood is not returning efficiently to the small vessels at the farthest reaches of your circulation. The mechanism is fundamentally about circulatory hierarchy. Your body maintains a strict priority system for blood distribution. The heart, brain, kidneys, and core vital organs are always serviced first. The fingers and toes sit at the end of the network. When overall blood flow efficiency is compromised by arterial stiffening, by reduced cardiac output, by plaque narrowing in peripheral vessels, the extremities are the first to show the deficit because they are the last to receive and the first to be sacrificed when the system is under pressure. Think of it like a city's water distribution grid. The neighborhoods closest to the central reservoir maintain strong pressure under almost any conditions. The neighborhoods at the far end of the pipe network lose pressure first whenever something upstream is wrong. Your fingertips are that far end of the network. Peripheral artery disease, the narrowing of arteries supplying the limbs through atherosclerotic plaque accumulation, affects approximately 8.5 million Americans over the age of 40, according to American Heart Association estimates, and its prevalence roughly doubles in the decade between 55 and 65. The clinical significance of peripheral artery disease extends well beyond the limbs because the same plaque-building process that narrows the arteries in your hands and legs is simultaneously narrowing the coronary arteries feeding your heart muscle and the carotid arteries feeding your brain. These are not different diseases with overlapping risk factors. They are the same disease expressing itself in multiple anatomical territories at once. The peripheral arteries show you the early edge of a process that is happening everywhere. Persistently cold hands, particularly when combined with prolonged capillary refill time, should prompt a conversation about peripheral vascular assessment, including an ankle brachial index test, a simple, non-invasive blood pressure comparison between the ankle and the upper arm that can detect significant arterial narrowing years before limb symptoms appear. It takes approximately 10 minutes and requires nothing more than 2 standard blood pressure cuffs and a Doppler probe. It is not routinely performed in most annual wellness visits. You may need to request it specifically. Sign number 2. There is a fine, rhythmic tremor in your hands when you hold them still, and neither caffeine nor anxiety fully explains it. Not all hand tremors are the same, and the differences between types carry distinct clinical implications that most people are never taught. An action tremor appears during voluntary movement, reaching, writing, lifting. A resting tremor is visible when the hands are relaxed and stationary in the lap. A postural tremor appears when you hold a specific position, like extending your arms with palms open. Resting tremor is the hallmark of Parkinson's disease and related conditions. Postural and action tremors are more commonly associated with essential tremor, the most prevalent movement disorder in adults over 60, affecting an estimated 4 to 5% of the general population over 65, according to data from the International Parkinson and Movement Disorder Society. Essential tremor is frequently misidentified as early Parkinson's disease, and the distinction carries real consequences because the two conditions have different trajectories, different treatment approaches, and different associated risks. Essential tremor, while not fatal, is associated in longitudinal research with modestly elevated risk of cognitive decline, a finding that has emerged from multiple independent cohort studies and that remains incompletely understood mechanistically. But here is the angle that almost no mainstream health discussion raises when it addresses hand tremors in adults over 55. Medication-induced tremor. This is not a rare phenomenon. It is an underdiagnosed one. Valproate and other anticonvulsants, lithium used in mood disorders, beta-agonist bronchodilators prescribed for respiratory conditions including asthma and chronic obstructive pulmonary disease. Certain antidepressants, particularly at higher doses including tricyclics and some selective serotonin reuptake inhibitors, and amiodarone used for cardiac arrhythmia. All of these are commonly prescribed to adults in the over 55 age group, and all of them are documented causes of tremor, either at therapeutic doses or following dose adjustments. A review published in the journal Drugs and Aging identified medication-induced tremor as one of the most systematically overlooked causes of new-onset hand tremor in patients over 60, specifically noting that clinicians often fail to establish the temporal connection between a medication change and tremor onset because the tremor can emerge weeks or months after the relevant prescription adjustment. The practical implication is that if you have developed a noticeable hand tremor in the past 1 to 2 years, the first diagnostic question is not whether you have a neurodegenerative disease. The first question is whether any medication was started, increased, or changed in the year preceding the tremor's appearance. Bring your complete medication list, prescriptions, over-the-counter medications, and regular supplements to that conversation because the interaction between multiple agents can produce or amplify tremor even when no single agent would produce it alone. Sign number 1. The sign that the largest cardiovascular epidemiology study of the last 20 years identified as a more powerful predictor of cardiovascular mortality than your systolic blood pressure reading. And we have been walking past it every single day. Grip strength. Most people over 55 relate to grip strength the way they relate to whether they can open a jar. Occasionally annoying, fundamentally not a health concern. That frame is wrong in a way that becomes almost difficult to believe once you see the data clearly. Here is what medicine told us for decades. Blood pressure is the gold standard screening tool for cardiovascular risk. Measure it at every visit. Adjust medications when it rises. The blood pressure cuff receives more diagnostic attention, more pharmaceutical investment, and more public health messaging than almost any other single metric in adult medicine. Blood pressure matters. This is not in dispute. Here is what medicine did not tell us. In 2015, the PURE study, the Prospective Urban-Rural Epidemiology Study, published its landmark findings in The Lancet. This was not a small trial with a narrow demographic. It enrolled 139,691 participants across 17 countries, spanning low-income, middle-income, and high-income populations across Asia, Africa, Europe, and the Americas. The research team measured grip strength with a standardized handheld dynamometer at enrollment, recorded blood pressure, and then followed participants for a mean of 4 years, tracking cardiovascular events, hospitalizations, and mortality. The result was striking. Every decrease in grip strength of 5 kilograms, approximately 11 pounds of hand force, was associated with a 17% increase in cardiovascular mortality, a 17% increase in all-cause mortality, a 9% increase in stroke risk, and a 7% increase in heart attack risk. When the researchers directly compared grip strength and systolic blood pressure as predictors of cardiovascular death, grip strength was the stronger predictor, not comparable in strength. Stronger. That finding ran through the mainstream medical press briefly, generated some academic commentary, and then largely disappeared from the public conversation. Because there is no pill for it. To be precise about what this finding means, grip strength does not cause heart disease. The relationship is not directly causal in that direction. What grip strength measures is the aggregate state of the biological systems that collectively determine your cardiovascular and metabolic trajectory. Muscle mass, mitochondrial efficiency, chronic inflammatory burden, hormonal environment, and the neuromuscular coordination that ties all of those together. When you squeeze a dynamometer as hard as you can, you are generating a single number that integrates all of those systems simultaneously. It is the cheapest, fastest, most comprehensive health test available to any adult over 50, and the majority of people in this age group have never been asked to do it. The reference thresholds matter. For men aged 55 to 64, normative grip strength data from large population studies consistently identifies clinically meaningful weakness at approximately 30 kilograms, 66 pounds of force in the dominant hand. For women in the same age range, the threshold is approximately 20 kilograms, 44 pounds. Below these thresholds, the research consistently associates substantially elevated risk of falls, hospitalization, incident cardiovascular disease, cognitive decline, and all-cause mortality. A 2019 systematic review published in the Journal of Cachexia, Sarcopenia, and Muscle analyzed 53 studies involving 133,000 older adults and found that low grip strength was associated with a 31% higher risk of all-cause mortality, a 23% higher risk of cardiovascular disease, and a 39% higher risk of disability. These are population-level associations. Individually, your risk depends on many intersecting factors. But the direction and the magnitude of these associations are consistent enough across studies and populations that ignoring grip strength as a metric after 55 is genuinely not defensible on evidential grounds. Now, here is where the invisible villain comes back into the story, because this is where the biology reaches into territory most people have never been shown. Sarcopenia, the progressive muscle loss I described at the start, is not simply a matter of muscles getting smaller from disuse. The mechanism reaches into glucose metabolism in a way that makes it directly central to the most common chronic disease trajectory in adults over 55. Skeletal muscle is the largest consumer of blood glucose after a meal. When you eat carbohydrates and blood glucose rises, roughly 80% of the resulting glucose is taken up by skeletal muscle under the influence of insulin. When muscle mass decreases, that uptake capacity decreases proportionally. The glucose has fewer places to go. The pancreas compensates by secreting more insulin. That compensation works for months, sometimes for years, and then it stops working as well as it did. Blood glucose begins drifting upward, and what was once a normal fasting glucose climbs into the pre-diabetic range, often without any subjective symptoms. What this means is that mainstream health communication has consistently presented this sequence in the wrong order. We say high blood sugar causes metabolic disease and then counsel people to eat less sugar. That is not wrong, it is incomplete. Because the structural reason blood sugar got elevated in the first place is frequently insufficient skeletal muscle mass to absorb it. The declining grip strength you observe on the outside is the visible edge of a deteriorating metabolic absorption capacity that is operating invisibly on the inside. Research from the American Diabetes Association found that each 10% increase in the ratio of skeletal muscle mass to total body weight was associated with an 11% reduction in insulin resistance and a 12% reduction in prediabetes incidence. That is a mechanism with a specific number, not a trend, a measured, quantified biological relationship. This also means that dietary intervention alone, without rebuilding muscle tissue, addresses the symptom of elevated blood glucose without addressing the underlying structural reason it elevated in the first place. Diet modifies the input. Muscle mass determines the disposal infrastructure. Both matter. Neither one substitutes for the other. The people who follow perfect diets in their late 50s and still cannot normalize their blood sugar markers are often the people whose muscle mass has quietly fallen below the threshold required for adequate glucose disposal, and nobody connected those two facts for them. There is also a psychological dimension to all of this that I want to spend a moment on, because the biology alone does not explain why this information is not more widely acted upon. There is a reason people over 55 do not know their grip strength number the way they know their blood pressure or their fasting glucose. It is not because grip strength is harder to measure. A basic handheld dynamometer costs between $20 and $40. The reason is structural and incentive-driven in a way that I find more absurd than enraging. The annual wellness visit in most healthcare systems is built around a standardized template: blood pressure, weight, basic metabolic panel, medication review, and liability documentation. Grip strength is not in that template. It is not in that template because there is no downstream pharmaceutical intervention attached to a low grip strength reading. There is no drug for sarcopenia. The effective intervention is resistance training and adequate dietary protein. Those are not prescribable products. They cannot be reimbursed by an insurance company. They do not generate revenue for a pharmaceutical manufacturer. Therefore, despite the most robust evidence base in aging epidemiology, they are not systematically measured for in clinical settings. I am not saying physicians are negligent. The doctors involved in my husband's care were excellent at the acute problem and genuinely caring about his long-term health. They are working within a system that was architecturally designed to treat disease after it arrives, not to prevent the biological conditions that produce disease in the first place. The system performs what it was designed and incentivized to perform. The gap is not cruelty. The gap is structural. Understanding that gap is the difference between waiting for it to catch you and deciding to operate slightly outside of it. Now, the grip audit. 3 components, specific numbers, 1 mistake that destroys the effectiveness of all 3 if left uncorrected. The first component is G. Get your baseline number. You cannot manage what you have not measured, and motivation without data is just a mood. Buy a JMAR-style handheld grip strength dynamometer. Search that exact term and you will find clinically validated options in the $20 to $40 range. Measure both hands, 3 trials each, seated with your elbow bent at 90 degrees and your wrist in a neutral position. Use the average of your 3 trials for each hand. Compare your dominant hand result against the normative thresholds. 30 kilograms for men 55 to 64, 20 kilograms for women in the same age range. Write the number down with the date. Retest every 8 weeks. The 8-week retesting interval is not arbitrary. It comes from resistance training intervention studies showing that meaningful grip strength improvements in adults over 50 become detectable within 6 to 8 weeks of structured progressive training. If you retest at 8 weeks and the number has not moved, something in your approach needs to change. The number is your feedback mechanism. The second component is R, resistance training, progressive and specific, not stretching, not low-impact aquatics, not brisk walking, as valuable as walking is for other reasons. Resistance training that places direct, progressive mechanical load on the muscles of the forearm and hand, applied with systematic increases in load over time. A meta-analysis published in the British Journal of Sports Medicine in 2017, examining resistance training effects on grip strength specifically in adults over 60, found that programs using progressive overload produced significantly larger grip strength gains than low-intensity functional exercise. The American College of Sports Medicine recommends 2 to 3 resistance training sessions per week for older adults, with sets of 8 to 12 repetitions at 60 to 70% of maximum effort. For the hands and forearms specifically, dead hangs from a horizontal bar, even 15 to 30 seconds at a time, produce remarkable loading of the intrinsic hand and forearm muscles and require no equipment beyond a bar you can hang from. Farmers' carries with moderate weight, plate pinches, and towel grip pulling exercises are similarly effective. Adults who go from zero resistance training to 2 sessions per week of moderate load whole body resistance work can expect, based on intervention trial data, to see 1 to 2 kilograms of grip strength improvement within the first 4 to 6 months. The third component is P protein threshold, and the current recommended thresholds are substantially higher than most people over 55 have ever been told. The older dietary reference intake of 46 grams per day for women and 56 grams per day for men, established in the 1980s, is now considered inadequate for muscle preservation in older adults by essentially every independent research group working in the field of muscle aging. The current consensus from the International Society of Sports Nutrition and Multiple Gerontology research programs is that adults over 55 need a minimum of 1.2 to 1.6 grams of protein per kilogram of body weight daily to support muscle maintenance and growth under training conditions. For a 70-kilogram woman, roughly 154 pounds, that means between 84 and 112 grams of protein per day. For an 80-kilogram man, between 96 and 128 grams. These numbers assume training stimulus is present. Protein without resistance training produces modest benefit. Resistance training without adequate protein produces modest benefit. Together, they are synergistic in a way the individual components are not. Research published in the American Journal of Clinical Nutrition found that combining resistance training with higher protein intake produced 30% greater improvements in lean body mass in older adults compared to either intervention in isolation. Additionally, distributing that protein across 3 to 4 meals of 30 to 40 grams each, rather than concentrating it in 1 or 2 large meals, produces meaningfully greater muscle protein synthesis responses, a finding that has come consistently from research by groups at the University of Texas Medical Branch and elsewhere studying protein utilization in aging muscle. The one mistake that invalidates all three of these components simultaneously: chronic low-grade inflammation. Specifically, the biological state researchers call inflammaging, a term introduced by Italian gerontologist Claudio Franceschi to describe the persistent, low-intensity inflammatory tone that characterizes aging and is dramatically amplified by ultra-processed food consumption, chronic sleep restriction, excess visceral fat, and sedentary behavior. When inflammaging is running at high baseline, the anabolic signaling cascade that resistance training and dietary protein are supposed to trigger is partially suppressed. The muscle-building machinery is present and theoretically capable. The inflammatory environment is continuously working against it, like trying to build a wall, while someone else is quietly removing the bricks from the other side. If your diet is substantially composed of ultra-processed foods, if your sleep is consistently under 6 hours per night, or if you carry significant visceral fat, the metabolically active fat stored around and between the abdominal organs, not the subcutaneous fat under the skin, your circulating concentrations of inflammatory markers, including C-reactive protein and interleukin-6, are chronically elevated in a way that directly impairs the anabolic response to training. You can follow the G, R, and P components of this protocol precisely and get perhaps 40% of the gains you should be seeing, because the biological environment needed to convert training stimulus and dietary protein into muscle tissue is compromised upstream. The specific lab marker to request: high-sensitivity C-reactive protein, written on a lab order as HSCRP. It is a standard test, typically covered at annual wellness visits. A result under 1 milligram per liter reflects low inflammatory burden and a favorable anabolic environment. A result above 3 milligrams per liter reflects significant chronic inflammation and will materially blunt your results from everything else in this protocol. If your HSCRP is above 3, that is the first problem to address, because nothing downstream works as well as it should until that number comes down. The most evidence-supported approaches for reducing HSCRP in this population are reducing ultra-processed food intake, improving sleep duration and quality, reducing visceral fat through caloric management and resistance training, and addressing any unmanaged inflammatory conditions with your physician. 6 signs: nail color telling you about your liver, your iron status, and your peripheral blood flow. Bow's lines giving you a stamped record of systemic disruption you may not have recognized when it happened. Dupuytren's contracture as a visible indicator of systemic metabolic dysfunction, sharing its root mechanism with liver fibrosis and vascular inflammation. Cold fingers and slow capillary refill as the peripheral expression of vascular aging that is simultaneously progressing in the coronary and carotid arteries. Hand tremor as both a neurological marker and a frequently overlooked medication side effect. And grip strength as the single most predictive, most practical, most actionable whole body health proxy available to any adult over 55. A number that the largest cardiovascular epidemiology study of the last 2 decades ranked above blood pressure as a predictor of who lives and who does not, and that the majority of people in this age group have never once been asked to measure. Your hands have been running this diagnostic the entire time, every day, without anyone asking them to. They were waiting for you to understand what they were saying. If you are starting the grip audit this week, measuring your baseline number, beginning progressive resistance training, and hitting your protein threshold, comment grip below so I can see who is actually doing this. And subscribe because the next video covers the specific inflammatory blood markers your annual checkup is almost certainly not running, what the normal reference ranges on your lab report are designed to miss, and exactly how to ask your doctor for what you actually need.